my name is Michael Borger. I'm the Chief of Cardiac Surgery at Leipzig, Germany, the Leipzig Heart Center. And it's my pleasure to host this symposium, which is being sponsored by Abbott. It's a very interesting symposium with very talented speakers, talented operators with live-in-a-box procedures. And we're looking very forward to learning more about transcatheter mitral valve replacement and repair. Why do we need both? These are my disclosures. So the session's objectives are to learn about expanded treatment options for functional and degenerative MR patients, to hear about the latest innovations in transcatheter mitral valve therapies, to tailor our treatment options in order to optimize patient outcomes using Tendyne and MitraClip G4 devices, and to review the current surgical options for MR, which is my job now with this presentation. As cardiac surgeons, we looked at Tyrone David in Toronto as the gold standard, and this paper published in JACC in 2019 looked at the very long-term results after mitral valve repair for degenerative MR. And as you can see in this figure, the long-term survival was excellent, over 60% at 20 years postoperatively, with a low amount of cardiac deaths and a very low rate of mitral valve reoperation. Only 4% 20 years after the surgery. In this curve, we can also see the low rate of recurrent, moderate or more mitral regurgitation, less than 20% 25 years after the repair. The survival of patients was dependent upon their preoperative clinical status. So there was worse survival for patients in class 3 or class 4 NYHA, arguing for possibly earlier intervention in the patient's pathology. One of the surgical principles of mitral valve repair, as stated by Carpentier, is the use of a mitral annuloplasty ring in order to restore leaflet coaptation, resulting in less subvalvular stress. And this is one of the criticisms of the MitraClip technique. And we know from Alfieri's group, this paper published 20 years ago already, that the long-term recurrent MR rates are higher for those patients that did not receive a annuloplasty at the time of surgery, in addition to their Alfieri edge-to-edge repair. However, this is an interesting paper from 2016, looking at the Framingham Heart group of patients that had some evidence of mitral valve degeneration, mitral valve prolapse, but no significant MR. These patients were followed up on an average of 11 years and compared to a control group, which is on the far right. And you can see that 11 years later, there was very minimal dilatation of the mitral annulus, which may be another argument for intervening earlier in the disease process. Now I will switch to functional MR. This slide shows that it's been estimated that there's over 800,000 patients in the United States alone with functional MR, and only 50,000 patients undergo surgery per year. So there is obviously a large clinically unmet need. Traditional surgical approach for functional MR has been the insertion of an undersized annuloplasty ring. However, we know that this is limited by persistent tethering, which can lead to recurrent MR over time. This randomized trial from CTSN was published 5 years ago in New England Journal of Medicine. And the primary outcome was comparison of left ventricular end systolic volume index between mitral valve repair and mitral valve replacement in patients with severe ischemic MR. And there was no significant difference between these two groups of patients. In addition, when they looked at survival, shown here, or freedom from MACE rate, shown here, there was also no significant difference between these two groups. So it appears that mitral valve replacement for functional MR is a reasonable option. Of course, one of the problems with the mitral repair group was the recurrent MR rate, as you see here, over 60% 2 years after the repair operation. In those patients that received a replacement, they were instructed to undergo preservation of the subvalvular apparatus, which previous investigators have shown results in better retention of LV geometry and function over time. And this is certainly what is being performed when one does a Tendyne procedure. But we as surgeons have always thought repair is much better than replacement. Although replacement results in better MR reduction, it's faster and more reproducible and requires less training. In mitral valve repair, we've been taught maintains LV geometry, is associated with improved patient survival, and has a lower risk of thromboembolism or endocarditis over time. And this has been the mantra that we've been teaching young surgeons over many years. However, it's very important to point out that these are based mostly on single case series, and they're all retrospective and non-randomized. There's obviously some patient selection bias involved, whereby we are more likely to replace the mitral valve in a patient with DMR if they are older or have more comorbidities. And we don't want to take the risk of having to go back on cardiopulmonary bypass a second time to re-repair the valve. And this has been pointed out quite nicely by the Cleveland Clinic group in this paper from several years ago, where they looked at 3,000 patients and looked at mitral valve repair versus replacement for DMR. And here you can see on the first line that there's already a big difference between these two patient groups, with an average age that is 13 years older in the mitral valve replacement. On this figure, you see mitral valve repair survival is the best in the yellow, and mitral valve replacement is the worst in the black. However, these two patient cohorts were very different, and when they performed propensity scoring matching, the two groups of patients actually had very similar long-term survival. And when they compared their survival to that of the age and sex-matched general US population, as shown in the green line here, they did not find any difference between these two treatment modalities and the general US population. They concluded that when valve pathology is complex so that a repair is not feasible, that valve replacement does not diminish long-term outcomes. So these are just some of the studies and data that provide food for thought, hopefully, for the rest of the presentations that you'll be hearing in this symposium.
Thank you very much for the invitation to give a presentation on the state-of-the-art MitraClip. Why do we have to move and need replacement? This is a presentation at EuroPCR 2021. Transcatheter mitral valve repair is available as mitral TEER as a US guideline recommended therapy for selected patients in both primary and secondary MR. Transcatheter mitral valve implantation is a new therapeutic option for selected patients. The Tendyne mitral valve system is the first commercially available device with CE mark in January 2020. So what are the patient selection criteria to change from a repair to a replacement strategy? We have a look in the guidelines in the latest position paper here from the German Cardiac Society as well as the European Society of Cardiology. You can see that TEER treatment and TMVR are more and more appreciated and set up in chronic secondary MR as an alternative treatment to surgical replacement and repair, mostly there in combination with revascularization. There are limits to the edge-to-edge therapy that is recommended. In morphology, we have patients with severe tethering of the posterior leaflet, as seen here at 12 o'clock on the left image, indentations and clefts that can make the success rate lower in mitral TEER, fibrosis, sclerosis, and mitral annular calcification, severe leaflet destruction, as you can see on the right-hand side. So the complexity of morphology can increase. From the surgical literature, we know that with also restricted mitral valve area, there are different screening pass rates to actually change from a mitral repair strategy to a mitral replacement strategy, where the right-sided image is most suitable. The mechanism of mitral valve repair and replacement is to change the vicious circle of a loading of the left ventricle and left atrium with increase of mean pressures, V waves, dilatation of the atrium and the ventricle. So it is important to unload both the left and the right ventricular system. The recommendation levels issued in the latest updates of the US guidelines give the TEER therapy a 2A recommendation, level of evidence B. We have an interaction of the mitral valve with LA and RV pressures, And we know that the result of the mitral regurgitation on tricuspid regurgitation is also outcome relevant. The better you treat the mitral regurgitation, the better is the improvement also on the right heart side. And you can see that we can achieve this in a series of over 600 patients in approximately 35% of the cases. You can also see that this change at 30 days is predictive on outcome and also on the situation at 1 year's time. There is a continuum from the surgical treatment over mitral TEER to a new therapy option, also in secondary MR and heart failure, with a replacement option and an apical tether. This moves the option from the latest generation of TEER with independent grasping and a nice control of 4 different sizes to the right side, transcatheter-based mitral valve replacement. And the system that is now CE marked is on the lower left, the Tendyne valve. There are, of course, also limitations and ranges for this situation. And as you can see, the septal or AP diameter can be treated between 25 and 42 millimeters. The intercommissural can be treated from 35 to 48 millimeters, and the parameter can be around 100 to 155 millimeters. These are the measurement points. The basic instruction to go from mitral TEER to mitral replacement, or TMVR, is to use CT as an additional measure. And CT gives us a lot of information on the neo-LVOT, on the parameter, on the size of the annulus, but also on the access route to access the valve. The change in hemodynamics is instant, and as you can see here, we have a comparative pressure line of the left ventricle and also of the right heart. And you can see that an implantation within minutes gives a complete unloading of the right heart in this Tendyne procedure. Another application point is TMVR in native MAC that can be done in the Guerrera classification from a mild to a moderate situation up to a score of 7. If we look into the heart team considerations based on the indication and the optimal therapy, you can see the basic thoughts here. So we have a certain left ventricular ejection fraction, about 30 centimeters. We should not have with the ECE mark a prior intervention. The patient should not be suitable for surgical repair or replacement, and it should tolerate anticoagulation. So the perfect candidates would have primary or secondary MR with elevated risk, do not meet TEER criteria, have anatomic criteria for the replacement, and have non-severe MAC. There are study data, as we know from the first 100 patient cohort, as you can see, with a high technical success rate, given here at 96% and an implant success of 97%, a decent mortality and a high SDS score. And as you can see, a high efficacy in reducing MR to a level of non-trace or mild. And you can also see that the New York Heart Association class changes favorable over the course of 2 years, as do the heart failure hospitalizations. So we'll see further insights in a randomized trial that will compare TEER to TVMR in the SUMMIT trial, where more than 200 patients are now being randomized. I come to the conclusion, the first 170 patients are commercially now treated in Europe and Israel. We have data from the SUMMIT trial and upcoming registry with TENDER and RESOLVE MR. There are anatomical limits to state-of-the-art MitraClip, and MR reduction is more pronounced, but mitral TEER may offer an early outcome advantage. Thank you very much for your kind attention.
The patient we have to treat is an 85-year-old female who was referred to our department for a class 3 NIOHA shortness of breath related to a severe primary MR. In the past medical history, we found hypertension, diabetes mellitus, and apical myocardial infarction complicated by apical calcified thrombus more than 10 years ago. She underwent also PCI on mid-LAD and right coronary artery in 2018. She's a very active woman, living independently at home without cognitive impairment and with no excessive frailty features. Laboratory investigations are unremarkable, no impairment of renal function. You see here the main results of the transthoracic echocardiogram. LVEF 60%, severe MR related to P2 prolapse. You see the quantifications. Mitral valve area 5.3 centimeters square, mean gradient 1 millimeter of mercury, no valvular disease or pulmonary hypertension. Here is an image of the calcified apical thrombus. Here in transesophageal echography, LVOT view, you see this very localized P2 prolapse with a height that is not too excessive. But here is in a 3D en-face view, a better overview of the mitral situation without color here and with color here. So in summary, we discussed this patient with our heart team. And regarding these octogenarian patients with good quality of life, no excessive frailty, severe impairment of quality of life, and anatomy suitable for edge-to-edge transcatheter mitral valve repair, this is definitely the solution that we found to be the most appropriate to this patient.
Welcome to Clinic Pasteur for this MitraClip G4 case. Didier, maybe you can summarize the objectives of this case after the case presentation you had.
Yeah, sure, Nico. So what are the objectives of this case? The first one is to highlight the changes brought by this new generation, the G4 of the MitraClip. And the second objective will be to discuss the determinants of choice between all the various iterations that are today available according to the patient anatomical features. Strategy-wise, so the patient is already under general anesthesia. We will get a 2D and 3D guidance provided by Laurent. And the key discussion will be focusing on the type of device we're going to use, whether it be a XT, XT-wide, NT, or NT-wide.
Didier, maybe you can comment a little bit on those new features of this G4 device.
Yeah. So mainly we keep the same architecture, the same structure for both the guide sheath and the sleeve. The only thing that is going to change is all about the clip delivery system. And as you can see, you can already identify, for those who are more familiar with the MitraClip, or even for those who are starting with it, that for the gripper component, we have two knobs that we can activate. So one of these knobs is going to control the anterior gripper. The other one is going to control the posterior gripper. What we can do is to try to understand what is the distribution of the gripper according to that knob. So Laurent, if you can show us the 3D image. And at the same time, as you see, we're seeing the clip a little bit from the side. And what I'm going to do is to bring down at the same time both grippers. You see them? Let me do it again. You see them going up and now gently down. Yeah, perfect. And one of them is going to activate the anterior gripper. So what I'm going to do is to decouple both grippers by lifting this handle. And then I'm going to just activate one of them, and you can see that this one is the one that controls the anterior gripper. So now I'm going to recouple both of them, just to be able to be sure that we can, at the start of the procedure, activate both at the same time. And if you want to achieve a differential grasping, we can do that by uncoupling, decoupling this knob. So here, what was one of the key determinants of the choice of NT-wide, this is an NT-wide, is more about the overall length of both the anterior and the posterior leaflet. And the posterior leaflet is quite short, so moving with the XT iteration is going to be potentially too aggressive. So we had something like leaflet to leaflet, something like 17 or 18 millimeters. So definitely an NT is more appropriate for this very small anatomy.
Let's try here. Okay, yeah. Posterior is in, the anterior also. Close. I release a little bit attention while you're closing.
Seems better now.
Yeah, it looks better. Good. So let's just assess now safety, efficacy, safety regarding the amount of leaflets grasped, efficacy regarding regurg, relief, and safety also regarding gradient.
The gradient,
we don't have a lot of concerns here. Okay, so Laurent, you have a doubt regarding the amount of anterior leaflets grasped, and so maybe we should check that and optimize the grasping. So what we're going to do, Didier, is just to open a little bit the arms.
Yeah, and I'm gonna lift the anterior gripper.
Okay.
And then open up a little bit while you can optimize towards the anterior.
Yeah. I'm currently pulling a little bit and tilting the clip more towards the anterior. Yeah.
Okay.
And now
so let's give it a try.
Yeah.
Okay.
Lower down again the anterior and reclose the clip. Okay, and it's better now.
Yeah, there is better
clearly better.
Yeah, it's clearly better. You see that the anterior leaflet has a better tension.
Yeah, definitely.
And for sure, we have more tissue. So again, one of the new features offered by this new generation clip, in case of any doubts, you can optimize grasping on one leaflet separately from the other without losing the benefit of having a good grasp at the location you want to have. So again, we recheck everything, gradient, the leak you saw, none. We're going to recheck the 3D.
It's true that this is not a feature that we may need on a regular basis, but in typical cases, maybe potentially less than 20% of the cases, this is extremely valuable for the optimization of the grasping.
And we see now the tension of the anterior leaflet that is more conventional, I would say.
Definitely.
More regular. Okay, so let's release the clip here. Okay, in 3D we still have our nice double orifice view, no residual prolapse seen. So that's what we want. And we didn't have any concern regarding the gradient. So thank you very much, and very interesting. Didier, maybe you can summarize the main learnings from this case.
Yeah, I think it was a very nice case just to illustrate the features of the G4 MitraClip. So we could see the sequential grasping. We could see how important it is to consider all the differences between the lengths and the width of the various iterations. And in this case, we had to choose an NTW that was appropriate for this particular patient. But it provides granularity in the decision-making for a single patient. We have a wider range of tools available, so we should be able to tailor the device to the patients.
Hello and welcome. My name is Michael Borger, and it's my honor to be the facilitator of this session. You can see we're joined here by Nicolas Dumonteil, who just showed this excellent presentation of this elderly woman getting a very nice result with a MitraClip procedure with the G4 device, and as well Hendrik. Hendrik and myself are both cardiac surgeons, but I think Hendrik has a much larger experience with these actual procedures in the operating room than I do, and therefore I would like to start with you, Hendrik, with my first question. Maybe before I get to the question, I would also like to mention that we have Paolo Denti, who is our chat master. So for those of you watching online who have questions, you can also feel free to put them in the chat, and then we'll relay them to us. Hendrik, I'll throw it open to you to discuss this case and maybe ask Nicolas a question or two.
So first of all, thanks, Nicolas. Great case, good example on how much advantage we can take of the new MitraClip generations. And especially in a key true prolapse and severe prolapsing case, I think it's really an advantage to have the sequential grasping mechanism available. That was a very good result. Of course, you can always argue that a key true prolapse is a very good case for a surgeon too, or this would be a very easy repair and surgery, but it's an 85-year-old lady. And of course, these days, we would never think about surgery anymore in such patients. And this was a very good example. But since we are now dealing with a patient with primary MR, maybe, Nicolas, you can comment on what your view is on the annulus enlargement that is very often accommodated with prolapses. And where are your, the borders here? I would think I'd wish to have something else. I would even go for a replacement device in such a patient when the annulus is too large, because we know from surgery data from the past that just correcting the prolapse alone in a patient with severe annular dilatation does not always have good long-term results.
Thank you, Hendrik, for this question. And you're right, the debate was well asked by the presentation of Michael initially in this session regarding this issue of having an annulus target as well as you target to repair the leaflets. I would be very simple, and I would just reflect on our local practice here. We have indication for edge-to-edge mitral repair in primary MR only for inoperable or high-risk contraindicated surgical patients. So basically, as you saw, it's always octogenarian or more of an octogenarian patient, very frail, very high risk for surgery. Most of the time, what we want is to have a clinical improvement, so coming down from pulmonary edema to a good quality of life. And we focus mainly on the anatomy of the leaflets in order to decide whether we offer edge-to-edge mitral repair. We know from previous reports that maybe as opposed to surgical edge-to-edge repair, transcatheter mitral valve edge-to-edge repair remodels a little bit the annulus. But even though we don't succeed in doing that using MitraClip, to my opinion, in such population with such life expectancy and clinical targets, it's not the main objective.
Nicolas, thanks very much. Maybe if I can make you squirm a little bit, especially for those people that are watching, where would you exactly say the annulus is just too large to attempt a repair? Can you give us a number?
No, that's so I'm going to rephrase that maybe to be more precise, but again, it's our local experience. We don't use a precise cutoff for annulus measurement to contraindicate a repair as long as we have overall and over valve anatomical factors that are making us think that the patient could be a good candidate for edge-to-edge repair. But again, I revert the question to you, and I would be interested whether you use such a cutoff in order to orient towards one therapy versus another.
Hendrik, do you want to give us a number?
There is no number actually, because you'd always, whenever you do a surgical repair, you use a ring. So you measure, of course, the ring size, but you would always use a ring in smaller sizes as well as in larger sizes. And the ring size is more or less defined by the length of the anterior leaflet. Then that gives you the hint to which ring to use. But coming back to the MitraClip, Nicolas, I think it's really now much improved, the use of the MitraClip, since we have the new sizes. We have now 4 sizes available. We have the XTW, the NTW. And maybe you can give us a bit more insight, since you're very experienced in this, on when do you use and what kind of clip, and what made you use the NTW in this particular patient as first choice, so that people more or less understand which clip to use and which pathology.
Yeah, thank you, Hendrik. As you mentioned, now we have to think about 2 elements. First, the length of the arm, and second, the width of the arms. So here, if we come back to that example, we chose the shortest length, so the NT length, because the baseline measurements of the posterior and the anterior leaflets that we made were more consistent to that size. And what we know from preliminary experience, because when we had the longest arms, the XT, that was released, we were a little bit tempted to use that, thinking that if we grasped more tissue, we would have a better quality repair. And in some anatomical conditions, we realized that we created some complications, some tears at the basal attachment of a leaflet. So we learned from that experience that you don't have to put an excessive tension on the leaflet, something that you perfectly know better than us for years, I guess. And in such anatomy, we chose the short length because the length of a posterior leaflet was not worth choosing a large length. Second choice is the width. And what we've learned also is in the setting of primary MR, have a perfect acute outcome, but on the follow-up, you can have, because of the tension of the dynamic of the valve, you can have some forces exerted on the clip that are creating late or secondary dislodgements or SLDA. So idea most of the time is to use two clips in such setting, and having now the choice to have a widest arm allows us, as it was showed in this example, maybe to use one clip in selected anatomies.
Nicolas, well, we could talk about the details here, I think, for a very long time, because we find this all very fascinating, very helpful. But I just have one more very quick question before we go to the next pre-recorded question. You said the lady had small anatomy. Do you sometimes see an actual change in gradients just based on the width of the device?
I don't have yet enough experience with this new iteration to answer to that, but it is, or it was, some of our theoretical concern at the time of choice. Not in this typical setting, but sometimes when you have on top of that some degree of MAC.
Okay, excellent. Thanks very much, Nicolas. And I'd just like to comment on what Hendrik said. I think, at least in Germany, we would all say 85-year-old transcatheter option is the correct and the best option. But that's not necessarily the reality in all countries. In France, certainly not in the US. And that's why it's going to be very important to see what the results of the Repair MR trial are, which I'll talk about a little bit in my final presentation. But we're going to proceed now with the next recorded presentation from Hendrik on state-of-the-art mitral valve replacement. Do we still need repair?
Thank you very much. It's now my pleasure to speak about state-of-the-art transcatheter mitral replacement. Will we still need to repair in the future? These are my disclosures. Well, when it comes to interventional mitral valve therapies, it's clear that it's a much more complex procedure compared to aortic technologies. The disadvantage of repair technologies is that you can only focus on one element of the mitral apparatus. You can either do annuloplasty or core replacement or use leaflet technologies like edge-to-edge repair. But the big advantage of a transcatheter mitral valve implantation would be that you could treat all pathologies. It will definitely eliminate MR and will preserve the subvalvular apparatus. It will also permit valve-on-valve implantations at a later stage. And then there are some morphologies where you just cannot repair. If you have heavy tethering, deep indentations or clefts, fibrosis, sclerosis, or even MAC, or severe leaflet destruction, then of course repair isn't possible at all, and you would have to do replacement. Nevertheless, we know from surgery that a good repair is always better than a replacement, but a replacement can still be much better than a bad repair. And with transcatheter technologies for replacement, there's also the promise that it would be less invasive than surgery and would be even more generalizable to transcatheter operators, being maybe an easier procedure compared to repairs, but only if the technical challenges can be overcome. And there are some technical challenges like the inflow sealing. We deal with a differently shaped atrial sealing zone that is a very dynamic situation and also affords preservation of the subvalvular apparatus. The biggest challenge, though, is the OT obstruction, and we know from experience that a certain percentage of patients will be excluded from such a therapy due to anatomical reasons and the risk of LVOT obstruction. This is the device we can implant today, the transcatheter mitral valve implant from Abbott, the Tendyne valve, the only CE mark device on the market. It's a dual frame stent design. There's a tri-leaflet bioprosthetic valve connected to it. And the stent is connected to a tether that's again connected to an apical PET. So somehow the valve is spun between the annulus
and the apex, and thereby securely fixed in the anatomy. It comes in multiple valve sizes and profiles. There's ongoing clinical studies to collect data on this valve, the global feasibility study, the Summit IDE trial, and even the MEC trial dealing with major annular calcifications. So far, more than 300 patients have been implanted with the Tendyne valve. And we can report the outcome of the first 100 patients after 2 years with a very high success rate of 97%, implant success and technical success at 96%. There was 0% procedural mortality, no strokes at all. And at 30 days, the early mortality with 6% was very low. This could also show that there was a complete relief of MR after Tendyne implant. Within the first 2 years, there was basically not a single patient who had more than first-degree MR. And also, we could not detect any signs of structural valve deterioration so far. The patient took also profit in terms of functional classification with good improvement in New York Heart Functional Class and also good improvement in quality of life scores within the first 2 years. At this very meeting, the EuroPCR 21, Stefan von Bardeleben could present the first results of the registry, a European registry of this valve, the so-called TENDER registry. And he could show that in 96 patients implanted in 25 centers throughout Europe, there was again 0 perioperative mortality and 100% successful implantation rate, what is really astonishing good. He could also report on 30-day data with, again, a complete relief of MR in 100% of patients. 30-day mortality was 9.4%, slightly elevated, but if you look at the patients treated, this is very acceptable. The vexing problem we deal with in transcatheter mitral valve replacement technologies is MEC, mitral annular calcification. It significantly increases surgical risk. It's a challenging anatomy for the implantation of conventional prosthesis. And here the Tendyne valve really has a potential to overcome this problem due to the apical securement by tether and PET. We know from Myra Guerrero that we should score the MEC degree from 0 to 10. And you can definitely implant the valve in up to moderate calcifications, but we know from experience that even severe calcifications in well-chosen patients, you can have very good results, like this one here, implanted by Paul Saraja in Minneapolis, with really severe calcification. There was data presented in 11 patients with, again, 100% success rate, and 50% of the patients underwent pre-dilatation by balloon. All-cause mortality here was 9%, and again, a complete relief of MR. So very promising results in terms of MEC. So to answer the question, will we still need to repair in the future? The clear answer would be yes, because percutaneous repair remains the gold standard for patients who are not suitable for surgery, with proven safety and efficacy and only few anatomical limitations. But if percutaneous repair is impossible, or even more importantly, a good result is improbable, then TMVR is a very valid alternative and maybe even the better choice. MEC has become a new indication for TMVR with the Tendyne valve. It's promising early results. And finally, patient anatomic characteristics should define which treatment to choose. And this should be done by an integrated heart team consisting of cardiac surgeons and cardiologists working closely together. Thank you very much for your attention.
Hello, everyone. It is my great pleasure to show you this case of a Tendyne in MEC implantation. This patient undoubtedly has severe mitral regurgitation, and it is a MEC case, so mitral annular calcification with some leaflet involvement. Tendyne is a transapical procedure, so a few centimeters skin incision on the left hemithorax is more than enough to expose the left ventricular apex. We're going to need rapid pacing for a specific part of the procedure. In this particular case, this patient did not have a previous procedure, so I'm opening the pericardium. And this is a finger poke test, which in the X-plane will make sure there's an orthogonal trajectory across the LV to make sure there is adequate approximation of the stent on the mitral annulus. The apex is secured in a standard fashion with 2 felt-pledgeted U-stitches to make sure that you're going to be able to safely close the apex after sheath removal. And as I said before, we're going to add an epicardial pacemaker lead, similar to the one we used when we were still doing transapical TAVRs. The groin instrumentation is rather straightforward. We are using a bifemoral puncture with two long 6 French sheaths to be able to place 2 pigtail catheters, one in the aortic root, one in the left ventricle for online trans-LVOT gradient assessment. This is a transvenous puncture for a right heart study, which we typically do before as well as after the procedure, including cardiac index measurements. This is a MAC case, as I said, so this is a transulnar 6 French sheath since the radial artery was not palpable. This is a sentinel cerebral protection device in a bovine arch. We typically go for a distal filter first placement, which is now deployed in the left common carotid artery, and here is the proximal filter in the brachycephalic trunk. You can already see the pigtail catheters in the root. This is the right heart study, as I said before, with a measurement of the cardiac index, typically before as well as after the procedure, to add to the assessment of treatment success. The next step then will be puncture of the left ventricle and traversal of the left ventricle with the floppy J wire. This is typically done under echo as well as fluoroscopic control, trying not to be entangled in the subvalvular apparatus, while the landing zone is rather obvious here from the MAC, which is visible on fluoro. The free traversal, non-entanglement, will need to be confirmed by a flossing maneuver. So this is a 7 French sheath, which sits in the LA, and we're following up with a standard PA balloon catheter and flossing a few times back and forth. So it's fine in this case. Now, this is special about this case. This is a 14 French Cook sheath, which we put into, advance across the mitral annulus to allow for a moderate and careful pre-ballooning of this valve. This is not pre-ballooning in order to dilate the annulus, which can be rather dangerous, I would say. It's just to displace calcific spicules, which are on the mitral annula leaflet or the mitral leaflets. This is done in the brief phase of rapid pacing, and now we're following up with the actual Tendyne sheath with the inflatable dilator. And once the sheath end, which has a fluoroscopic marker, has passed the mitral annulus, the dilator can be deflated and removed, as well as the wire. This is from now on not anymore an over-the-wire technique. And now the primary operator is going to hold the Tendyne sheath central in the valve, where the second operator is advancing the valve through the stent. By the way, look at this, 4 hands, 2 from a cardiologist, 2 from a cardiac surgeon. Could it be more symbolic of the heart team than this? Anyhow, once the stent is towards the end of the sheath, the effectuator wheel 3 is used for final deployment after adequate rotational alignment is confirmed by echo, and then you can go quickly in order to release the outflow of the stent. Sometimes there is a brief phase of hemodynamic compromise with stop flow, but typically this is brief and overcome quickly. Next step would be to disconnect the sheath or the deployment catheter from the tether, which now holds the valve in place. The second operator to the left in the image is holding the end of the tether, while the primary operator is removing the sheath and securing the apex by tightening the purse strings. Now we're coming out with the catheter. Next step would be to fix the tether against the black box at the end, which also has a traction transducer. And now the task of the primary operator is to maneuver the fixation pad through the thoracic access, there's a tilting function if you're using minimal access like this one. And now all that's left to do is determining the correct tether tension. While you're doing this, you can already appreciate that there's a good seating of the valve. There's pre-existing mild aortic regurgitation. And once tether traction is confirmed to be adequate, the pad fixation tool can be released and retracted from the thorax, as you can appreciate right here. And then all that's left to do is knotting down your purse strings, shortening the tether, of course. While you're doing this, there's, of course, ample time for further echo studies. And now our next step would be to remove the sentinel device and repeat our right heart study. While again, you're seeing a few nice echo images. As I said, mild aortic regurgitation was present before. I tend to close the pericardium to shield off the fixation pad rather, against the thoracic wall. And then all you need to do is put in a pleural drainage and close the thoracic access. So I think this was a nice case to demonstrate the Tendyne technology, even though it was a somewhat specific case. These patients benefit substantially from this procedure, especially since the alternative treatment options are not as optimal. So, and with that, I would like to thank you for your attention.
Well, thanks very much, Lenard. That was a fantastic presentation, and we're joined by all speakers and operators now. Maybe if I can start with the first question, Lenard, you said the balloon valvuloplasty to sort of displace some of those spicules of calcium rather than trying to enlarge the calcified annulus. I have to say I've done several open procedures where we will put in a balloon expandable transcatheter aortic valve, not really made for the mitral position, but we've used it out of necessity in the past. And even with massive pressure in the balloon, I've not seen a single rupture of that calcified annulus, which is not too surprising to me. That calcium is really, really, really rock stable. But that leads to my question. Is there a risk that the devices do not completely expand and achieve a physiologic shape, and that this may have some detrimental long-term effects?
Thanks, Michael, for that question. So I think, first of all, this was a proposal by the company, and at that time point, we didn't have much experience with it. So I just was happy to follow that because I thought this was maybe an additional maneuver, but probably little harmful. So I would always do this kind of, opening up of the valve as soon as a predicted interaction of leaflet calcification would infringe with the internal of the two Tendyne stent frames portions. I think a sealing, it doesn't really occur at at least not isolatedly occur at the leaflet level, but rather at the annular level. So I wouldn't be worried about that. But as soon as there is projection of calcium towards the inner stent frame, I would go along with this. It's a small step, takes a few minutes, no harm done in most cases, I guess.
This whole session is about when we want to use replacement, when repair, of course, when we want to use surgery. Stefan, I have a question for you then. In tailoring the treatment strategy to the patient, do you think that there's going to be a role in the future for earlier transcatheter repair? So I showed you the data from surgical experience from Tyrone David's series, and there's been many series that have shown the same. The more advanced symptoms the patients have, the worse the long-term outcomes. And also there's that interesting framing and heart study showing basically MR begets annular dilatation begets MR. So should we be looking at trying to intervene earlier in the disease process for patients with MR?
I totally agree, Michael. We have experience now in over 110,000 mitral tear procedures, and we know it's a very safe procedure. So the mortality here is now currently around 1.5 to 2% at 30 days, which is very, very acceptable. We have shown that we should not wait for tricuspid regurgitation to appear, but to treat earlier. As you said, the unloading is very important. And the earlier you treat, actually, the better the prognostic outcome is. What you also showed is that repair in DMR in surgery is at a mean age of 57. The mean age for DMR in transcatheter methods is 78 to 85, as you've seen nicely also in the live case from Nicolas Dumonteil. So I totally agree with you. We should not wait for the prolapse to persist. We should not look at the severe regurgitation to beget TR. And we should treat those patients, especially if they're old, if the annulus is not too much dilated, with repair technologies, especially if the patient is old. And if we need a long-term situation, we should also think that replacement may be an option, actually. But the patient has to get the benefits over the procedure itself. So I think especially to gain the benefit of 98% MR1 plus or less, you also should have life expectancy that is long enough. So this would be actually the things I would care about. And I totally agree on the Framingham study. And we will learn more long-term results actually with the current trials that will go on for 5 years, also in the Summit trial and in other trials that are currently done, not only in DMR, but also in FMR. So I think there's more to come in randomized controlled trials on these aspects that you just mentioned.
Nicolas, maybe I can ask you another question. Some of the early contraindications to TEER therapy we've now shown that we can safely and effectively treat those more complex pathologies. What are the pathologies that you now treat on a routine basis that 5 years ago was thought to be impossible?
I would say maybe not only a central disease. We saw an example of a P2 prolapse, and now we've learned, especially benefiting from the experience of our German colleagues, that we can treat non-central disease with quite good and beautiful outcomes. I would say also some patients with some degree of MAC, depending on more precise anatomical conditions.
I'll ask Hendrik one more question. Hendrik, the results of the Tendyne for MAC seem to be better than the other options, in particular transfemoral and transapical balloon expandable valve. Do you think this is because the Tendyne is uniquely suited for this anatomy, or was that better patient selection?
Oh no, it's clearly better suited for this anatomy because there's a dual stent design and you do not rely on a stent that's fixed in the calcium. The fixation mechanism stays the same, so it's still an apical pad that fixes the valve in the annulus, but the sealing is much better. So I would say since we now have Tendyne, we should totally forget about placing sapiens in such anatomies because it can be such a mess, as we all know, because we made all these experiences. So I would rather go for a Tendyne in these anatomies unless, they are really unsuitable. But then I really ask myself if the balloon expandable valves in these situations are good alternatives. I really doubt this.
But as you know, the balloon expandable valves, the main problem that leading to major complications was LVOT obstruction. Maybe I'll ask Stefan this. Is the Tendyne less amenable to LVOT obstruction when you're doing these cases than a balloon expandable option?
Yes, I think so. It was also the experience with the balloon expandable THV valves was that they tilted over time towards the LVOT. So it was not only a problem at the time of the procedure, but on follow-up over the first 6 months. So the seating is much more straight. And we have also the low profile situation, which made a big change in those MAC patients. So the standard profile Tendyne valve is less suited than the low profile valve, which has a larger clearance for the LVOT and is better suited actually to be sealed and to be deployed in a smaller annulus. Also, we have to see that the balloon expandable valve has both to attach to the MAC. It has to get round at the same time than the sealing. So you only have one stent. The Tendyne has the unique advantage that we have a very compliant outer stent that adapts to seal, and we have a more rigid inner stent that keeps the valve in a round shape. So I think this design, as already Hendrik mentioned it, is unique to allow, together with the tether, a very high sealing rate together with a high expansion rate of the inner valve. And that's the key point. Also, you have a better anchor for future THV valves in the Tendyne prosthesis after 10 or 15 years. So this may also be beneficial for younger MAC patients. So instead of decalcifying the ring with a potential LV rupture, I think Tendyne will become the standard of care, at least in moderate MAC patients.
Yeah, that's a great intro for my summary statement. Then we've just got a couple minutes left. And before I forget, I would like to thank Abbott very much for the opportunity to present today and to see these fantastic presentations. As far as the key learnings are concerned, we can see that the transcatheter repair with the MitraClip device is a very, very safe and a very effective procedure. As Stefan mentioned, there's been over 100,000 implants, and there's also been a lot of follow-up already. We have over 13 years of post-clinical approval follow-up to date. And there's been also a tremendous amount of academic activity with over 2,000 publications on the MitraClip device, and certainly new off-label uses, which are very interesting, such as in the tricuspid position. What's very interesting for the TEER therapy is the upcoming repair or the ongoing repair MR trial, which is a randomized study of intermediate risk patients with degenerative MR. And this trial is randomizing 500 patients to either surgical repair or MitraClip device. And intermediate risk means that they have to be 75 years of age or over, or the patients have to have an STS risk score of 2 or more. And I think this will certainly be very informative and drive future therapy of patients with DMR, with lower risk patients, at least for the foreseeable future, remaining in the realm of surgery. And then finally, I just want to mention the Summit trial for the Tendyne device. The Tendyne device has been implanted clinically and in clinical trials, so post-approval and in clinical trials in already over 600 patients, and has been shown to be safe and very, very effective. And we are waiting for the long-term results to confirm that effectiveness, but we don't expect to see a lot of problems. But the Summit trial is particularly interesting in that patients are being randomized to either MitraClip therapy or a Tendyne device. As you saw in my presentation, there can be made some good arguments that replacement is just as good of an option for patients as repair. And this will be 900 patients in total, including a subgroup of patients with severe MAC. So we're looking very forward to seeing the results of those two trials. So once again, I would like to thank my excellent panel for the tremendous presentations, very informative, very educational, and for Abbott for the opportunity to present today. We return back to our regular program. Thank you very much.